Good afternoon to one and all present here. On behalf of Dr. Agarwal's Institute of Optometry, I warmly welcome today's moderator. It is a pleasure to introduce today Mr. Sai Tirumala De Kalicheti, an assistant professor of optometry at Chetkara University, Punjab, and a PhD scholar in vision science. With over 6.5 years of academic experience, he has mentored more than 300 students, particularly in clinical reasoning, research methodology, and professional growth. He is also an innovator, holding a sixth patent in areas such as ophthalmic devices, VR-based ocular therapy, low vision rehabilitation, along with several peer-reviewed publications. He is a fellow of the Academy of Clear Contact Lenses, Low Vision, and a permanent member of Optometry Council of India. His key areas of expertise includes clear lenses fitting assessment, innovative teaching technologies. We are delighted to have him today. So let's welcome Mr. Dev Kalicheti, sir.
Thank you for giving me such a wonderful welcome. We can continue with the case presentation.
Thank you, sir. And also, we warmly welcome our team member, internship at Ms. Jemima Eobert, ma'am. And today's presenter, Yogapriyadharshini, she'll be presenting on a topic of traumatic macular hole with burning edema. Over to you, Yogapriyadharshini. You can start presenting.
Yeah. Good afternoon to one and all present here. I'm Yogapriyadharshini, pursuing my internship at Dr. Agarwal's Institute of Optometry, and today's my topic is traumatic macular hole with Berlin edema. So, coming to the patient history, a 9 years old male came with the complaints of injury on the right eye with the crackers and taken first aid. And the ophthalmic history and the systemic history of his was none. The ocular examination of the patient in the right eye was the appearance is normal and the appendages is seems aberrations over the lateral part of the upper eyelid and the upper eyelid edema and the bruising of the eye which is called ecchymosis. In the conjunctiva, the congestion is generalized with the subconjunctival hemorrhage. Diffuse subconjunctival hemorrhage is seen and no FB foreign body is seen and the edema is present. This conjunctival staining with the subconjunctival hemorrhage at the limbus at 8 o'clock position to rule out the foreign body is also be done. The sclera is normal and the cornea seems to have temporal SPKs, which is superficial punctate keratitis, localized in the 8 o'clock position at the corneal staining. And the Seedles test states negative. The Seedles test is done to assess the aqueous humor leakage from the aqueous at anterior chamber due to the trauma. And the Seedle test states negative, which is the patient has no leakage from the aqueous humor. In the anterior chamber, the hyphema is present. The hyphema with staining temporally with a thin fibrin membrane with hyphema at pupillary margin. And the pupil shape is normal. Reaction of light is sluggish, and the reaction to light in consensual is sluggish. The iris stays within normal limits. In the lens, the fibrin membrane is present, and the blood clot in the anterior lens capsule is also present. The in the left eye, the lid, the conjunctiva, and the sclera, cornea, anterior chamber, pupils, iris, lens is all normal and within normal limits. In the fundus examination of the right eye, the media is hazy due to the hyphema present in the anterior chamber, and the cup disc ratio is 0.3 mm. No absent of posterior vitreous detachment, and the optic disc size is medium, and the disc was healthy. The blood vessels is normal, and the macula is in hazy view. And in the digital IOP, it is in the normal. In the left eye, the media is clear and the cup disc ratio and the blood vessels and the macula has foveal reflex and everything is within the normal limits. In the diagnosis, the optal investigations has been done for this patient is B scan. In the B scan, there is no vitreous detachment or any blood clots, blood cells is seen in the B scan. And the medications was given to this patient is prednisone for to reduce the IOP, and homide for to dilate the eye to check uh, the posterior segment of the eye, and moxicram antibiotics and some drops, lubrication drops is given. In the first visit, the visual acuity of the patient in the right eye was 4 by 60, and the IOP is within normal. In right eye, it is 15 mmHg, and in left eye, it is 18 mmHg. And in the extraocular movement, there is full, free, and painless in both the eyes. So, in the first review of the patient, in the slit lamp examination, in the right eye, the appearance was normal, and in the appendages, the periorbital edema, the tissues around the eyelids have swelling, and the patient feels no tenderness, no pain, uh, uh, like it's not soft like that, and the orbital rim is intact. The conjunctiva is normal, and the sclera is normal. The cornea size, shape, and surface is normal. In the anterior chamber, streak hyphema is seen with no fibrin membrane. The pupil shape is normal, and it is dilated due to the homemade medicine given to the patient, and the iris is seen within the normal limits. So, in the first review, the patient was told to take the FFA fundus photo in NIDEC, and there is a cherry red spot seen in the macular region. And the OCT report also shows macular hole in the right eye, and the same medications is being continued. In the second visit, the patient's visual acuity is slightly improved to 4 by 60 to 3 by 60, and with the pinhole it was 6 by 36, and in the left eye it is normal. And in the slit lamp examination, the appendages was normal. The hemorrhage, subconjunctival hemorrhage, and the edema is all uh, relieved, and the sclera is normal, and the cornea is, size, shape, and surface is normal. And the anterior chamber, there is no fibrin membrane, there is no blood clotting response, hyphema, and everything is came to normal. And the pupil has round shape, normal, direct, and consensual reflex. And the lens was clear, crystalline, and central. In the fundus, it shows the traumatic full thickness macular hole with the resolving Berlin's edema and inferior vitreous hemorrhage. And the OCT report shows still the macular hole is present. And the advice given to the patient is to observe, and the follow up will be taken after 2 weeks. And after 2 weeks, in the third visit, the patient's visual acuity is improved to 3 by 60. In the last visit, he has 3 by 60 with the pinhole of 6 by 36. In the third visit, the patient right eye visual acuity is improved to 6 by 60. With pinhole, it is 6 by 36, and the left eye is normal. In the slit lamp examination, everything seems to be normal, and in the fundus view, there is still macular hole is present. Though the visual acuity and the vision is improving for the patient, but the macular hole is still existing. So after the third visit, the advice given to the patient was to be right eye to be need for surgical intervention, and the surgery procedure is explained for the patient. And in the case of this patient, the Berlin edema is present, and the Berlin edema is also known as commotio retinae. Is an acute traumatic maculopathy which is caused due to an trauma, which is caused due to a blunt injury in the eye. This was first described by the German ophthalmologist Rudolf Berlin, and it is characterized by transient retinal whitening, which is seen in the fundus photo. Here, there is whitening in the macular region, like striations like whitening in the macular region, and the cherry red spot is also seen in the fovea macular region. So yeah, it is characterized by transient retinal whitening, primarily affecting the photoreceptor outer segments and retinal pigment epithelium, leading to decreased vision. Despite its name, it is not a true edema due to the extracellular fluid accumulation, but rather result of cellular damage and disruption of the retinal structure. So, macular hole with Berlin edema is a condition resulting from blunt ocular trauma, where both the traumatic macular hole and Berlin edema is present simultaneously. So, Berlin edema involves acute disruption of the photoreceptors, outer segments, and retinal pigment epithelium due to a blunt trauma or mechanical forces, typically following trauma. So, thus, due to the disruption in the retinal tissues, the macular hole arises from the anterior, posterior, and tangential vitreoretinal traction. Thank you.
Uh, Good, Yogapriyadharshini. It's a very interesting case which you have presented. I think there's a lot of learning we can do out of this case, so we'll go one by one. First, can I ask you why did they do B scan and waited for OCT for the second visit? What do you think? Or not only Yogapriyadharshini, anyone in this interns group can answer this question. Why the initial
Sir, the
investigation?
B
Yeah,
scan is taken due to there is any uh, detachment in the posterior section, or there is any vitreous hemorrhage present,
a
because there is
very
an aqueous humor in the aqueous chamber, there is hyphema present and the media is hazy. So to view the posterior segment, the B scan is taken, sir.
the key word you just mentioned is detachment. So fundamentally, the doctor want to know either there is a
Yeah.
retinal detachment because retinal detachment is a bigger issue than a macular hole. So they try to diagnose that with a B scan. Is there any retinal detachment? That is one learning outcome we all should learn out of this case. And this case involves a 9-year-old male with a blunt trauma. Yoga Priyadarshini or anyone, can you tell me what is the opposite of blunt and what is the exact meaning of here blunt? Okay, I will explain. So there are two types of globe injuries. One is blunt injury, other is penetrating or perforating injury. A penetrating and perforating injury is much more dangerous compared to a blunt. Blunt means that there is a shock wave. So since it is a firecracker injury, there must be a blast or the person is very near to where there is certain kind of blast happen. And the shock waves have made the globe to become flat and again come back. In this process, the layers of retina got disturbed. And one more thing is that you are telling that there is a cherry red spot. And do you think in this case there will be cherry red spot? Whatever red spot you're seeing on your fundus. Can anyone, can you move the slide to fundus? Yeah, you can stop at the fundus. So the red spot you are seeing is actually choroid visible. It is not the cherry red spot which you see in CRA. So if there is a full thickness macular hole, so RPE layers and photoreceptor layers, there is a tear. Like there is a separation, not tear, we cannot call it separation. And yours, whatever you're seeing, the red spot is actually the choroid, the blood layer of the retina, so blood layer of the eyeball, which you're able to see. That is what, that's the reason you're seeing that red color. Okay. That is one
Red
small
spot. Okay.
correction I want to give to you. And here in this case, a blunt trauma means that the globe has become flat on the backside and it again regained its shape. When it regained its shape, the neurosensory retina and the mechanical retina got detached. Can you tell me the
Okay.
layers of retina where it exactly this detachment happened? Can anyone tell what are the
The
10 layers of
RP
retina?
from the
What are the 10 layers of retina?
red
So from outer to inner, first is your RPE. Then you have photoreceptor layer. Then we have
cell.
external limiting membrane. So exactly at this place, there is a tear or you can call it separation. And because of this separation, your macula already has very fine number of layers. So there is a full thickness macular hole. And
Yes,
if
sir.
you go to the management of this case, you were telling that they gave a drug, Lotipress. What is the Lotipress is given? Can you think of what is it and why it is given and how it helps this patient?
Mm,
So Lotipress is a latanoprost, basically a prostaglandin, which is given to lower the IOP. Why in this case the IOP
yeah.
will increase in this patient?
Due to the hyphema present in the aqueous,
Very good, very
like
good.
anterior chamber. Yeah.
So the initial IOP was 15 and 19. You also told about test called CEDAS negative. That is also very
C is
important
negative.
test
Yes,
to
sir.
test that there is no hypotonia. And
Like aqueous humor leakage
there is also homide
leaks
is
from the
prescribed,
aqueous humor.
right?
Yeah.
Why homide is prescribed?
Homide is prescribed for the dilation to check the entire eye examination from posterior side.
No. Homide
Mm.
is given to fix the ciliary spasm. What is ciliary spasm? Whenever your eyeball goes under shock in this kind of blunt traumas, the ciliary muscle goes into spasm. So that
Okay.
spasm will cause pain in the eyeball. So to reduce that eyeball pain and also prevent synachia, posterior synachia or anterior synachia. What is synachia? Can anyone tell me?
Yeah.
Attachment of iris to the lens or attachment of iris to the cornea. About medical management. In this case, the patient was prescribed steroids. Can anyone tell why steroids are used and what is the use of steroids? How steroids will help this patient?
Steroids can help to prevent from infections
No,
like
no.
that, sir.
Steroids blocks the inflammation, secondary inflammation. Exactly. So what happens in this case is that that inflammation will cause more increase in IOP and the recovery of the from the blunt trauma becomes slower. So steroids are
Slower.
given both eye Bedford eye drops are given and Winestone is also given 10 mg. Now what is the
Yeah,
side
yes, sir.
effect?
In the second visit, it is given.
What is the side effect of taking Winestone? So the patient will have fluid
The
retention.
cornea will. Okay.
The that is, but there is a fluid, the patient may retain lot of fluid and it will put stress on their kidneys and all. So whenever we are giving steroids, and another thing is IOP. So whenever you give a
Mm.
lot of steroid, the IOP also may go high. So since the boy is very 9 years old, younger, he has that ability. But in old age people, you have to be careful in giving this steroid, if at all whoever are using it. Then you will also see that they have given IOP lowering lubricants and other alternatives. So this is a
Yeah.
standard surgical. Now in the last visit, you told that vision did not improve beyond 6 by 60 with pinhole 6 by 36. What is the surgical management which is suggested in this case?
Surgical management.
So it would be PPV, pars plana vitrectomy with the internal limiting membrane, peeling, and a gas tamponade. They fill this person with gas like CF8 or any
Yes.
fluorine gas they will fill with ILM peeling because with the vitro retinal traction, it would have
Traction.
caused, yeah, that would have caused a certain amount of fibrils to grow, fibrin material. So they give this surgical management. So although from optometric point of view, this case involves refraction. Have you seen hyperopic refractive error? So if you see the preliminary visit, the plus is very, very high. As the visit is on January 16, the patient came with a very high plus 1.75. But as the edema is decreasing, you are seeing less plus. As we move forward, we got only plus 0.7. So one of the learning outcome from this case is that uh, in initial stages when the edema is very high, the plus would be very high.
Yeah, sir.
And as we move forward, you will get less amount of plus. That is one thing. Then you should also know the 10 layers of retina and how to interpret the OCT. This is a very important learning for every optometrist. And now you may ask me a question: why the vision from 6 by 3 by 60 did not improve beyond 6 by 36? That is one of the reason. The reason for that is there in the foveal reflex. What is the foveal reflex that is documented?
In the second visit, are you asking about the second visit, sir?
Yes, first visit there was not visible. We did B scan, but in the second visit they documented foveal reflex. It is dull. Okay, so
Okay.
retina is like a mirror. So when you go and see your face in a brand new mirror in a mall, you will see it is very shiny and good. But let's say you have an old mirror in your home. Whenever you see in that, your face will be little dull because the silver layer behind that mirror is degraded or degenerated. Same thing happens with retina. In this case also,
Okay.
when a neurosensory retina, that is RPE, got disturbed and the photoreceptor layers got disturbed, the foveal reflex has become dull. So the neural conduction has been disturbed. That is one of the reason why the vision is not improving beyond 6 by 60. So how to
And
improve?
it is also due to the cell damage, sir.
Yeah, definitely. The
We take it,
foveal,
yeah.
that is because of cell damage. And how do we
So due to
confirm
the
this?
retina is whitening of the retina and the
Mm,
edema is present.
And how do
So
we suppose, let's say you are an optometrist, you are not having authority to dilate and see. How do we quickly confirm this with the pupil reaction? If you see the documentation of pupil, sluggish pupillary reaction.
sluggish in the direct and consensual reflex. Yeah.
Mm. That means basically the electricity flow from the eyeball to the brain is disturbed. That happened because the separation between neurosensory retina and the mechanical retina. Okay.
Okay.
So your pupil is one of the quick tests which you can do. And
Okay.
what can be the prognosis for this patient? Or how do you counsel this patient? Mm. So if you have to send this patient for low vision, because this case ultimately comes to an optometrist at the low vision level in which I specialize. So tell me, how will you manage this case from the low vision point of view?
So um, by giving
By giving
spectacle in spectacle magnifier for distance.
no spectacle magnifiers are not given for distance; it is given for near. So ultimately, the person will have central scotoma. What do you mean by central scotoma? An area in the retina around 5 degrees or 10
Non
degrees
seen area in the central zone.
central zone. So you
Yeah.
Basically, there is a well, you have to magnify the image to fill so much that it comes out of the well. So we
Mm.
suggest magnifiers. For distance, we give telescope, and for near, we give magnifiers. It can be spectacle magnifier, stand magnifier, dome magnifier, whatever it is. That will be. Second thing, will you do anything in the form of lighting for this
Lighting.
patient? Yeah. Although other eye is 6/6 and but binocularity is lost, right? So to improve
Yeah,
their
yes, sir.
stereopsis and better, you have to always ask them to go for better lighting so that their
Okay.
binocularity is intact. And overall, you have to see after past planar vitrectomy, if the macular hole closes and the neural conduction
Okay, sir.
develops, okay, this case may become normal also.
Will this patient be amblyopic, sir? Like
No, the
in
critical
the
age
future?
very rare because the age is 9 years. The critical age is still 8 years. So most of your, if at all has amblyopia has to develop, the same kind of problem it would have come at very young age. But yet there is a chance, but not at a very higher level of amblyopia. Very lower level of
Mm.
amblyopia can arise because still 8, 9 years the patient has seen with both eyes with 6/6 vision. The neural pathways will develop, but the patient may not develop amblyopia instantaneously, but it is left like that, definitely sure the vision will be amblyopic after correction. Yeah, but
Mm.
it may not be so dense amblyopia. So because whenever we talk about amblyo, we have to talk about depth of separation and area of separation also. That may not be higher, and it will be easily treatable if at all there is a here there is more pathophysiological changes that happen because of blunt trauma. I have seen such kind of cases which develop 6/6 parts. They will definitely not become 6/6, but there's a high chance that they end up with 6/6 parts and a stereopsis of 1200 arc seconds, which is enough to do daily activities.
Okay.
And the steroids which given will actually stabilize the blood retinal barrier. And whatever you have seen is a more of ophthalmological management. Whatever I have discussed is more about optometric
Optometry,
management.
man. Yeah.
Okay. So that
Okay.
is the so you should know what is penetrating trauma and blunt trauma. You should know about this signs. But it's a very good case. Berlin edema is a pseudo edema basically. There is no
Mm.
true accumulation. It
True
is
edema, there is no true edema due to fluid accumulation.
so this is very common. That's the reason we have to counsel during Diwali and all these times. Whenever these 100 shots, 200 shots, there are a lot of instances where people go near and think that why still the sky rocket shots are not forming, and it suddenly blast. And I have seen a number of cases. We like retinoschisis. We also call this with other name called retinoschisis, where the interior layers of retina get separated. Here there is a full thickness macular hole. There are cases of retinoschisis also. In those cases
Okay.
also, the people will have sluggish pupil reaction. Their color vision will get affected, and they'll have contrast sensitivity problem. Okay.
Okay.
I have added whatever I can. I think others can add.
Thank you for sharing the valuable insights, sir. So much of information for our students and boost our case presentation reports as well. Thank you for that, sir. And
Thank you.
thank you, Yogapriyadharshini, for sharing the case report. And this shows like lots of research are done, work and rework are done for the case reports. And this shows also your dedication as well. So
Thank you,
thank
ma'am.
you for presenting.
Thank you all.
So students, if you have any doubts, you can post in a chat box.
Yeah, anyone, if you have any doubts, feel free to get it clarified. So I would like to thank Dave for joining us and giving us your valuable inputs.
Thank you, ma'am, for giving this opportunity.
Thank you. It was very nice where you have, made sure that you have covered all the topics under this. Very nice. So two things I would like to highlight is, see, homemade drop, generally it is used as a cycloplegic drops. But in such cases, in uveitis and other cases, we as optometrist students, you should all know the uses of homemade. So her sir told 2 points about homemade. Can anyone repeat that? What is the use of homemade in this particular case?
To reduce this ciliary spasm
Okay, so they
due to
will
the
have
trauma.
so they will have pain, and that is one reason. And then what is the other reason? To make sure that Sinike is not formed. Okay, so that you should all remember. And next is again spectacle magnifier. Many students make this mistake, so I would again insist on that. Spectacle magnifiers are mainly for near. It is not for distance. Okay, distance it will be telescopes and other aids. Spectacle magnifiers is only for near. So please make sure you note it down. So I do hope that you are all taking notes during these sessions, because questions will be asked at the end of the semester. During our assessment, all these points will be covered. So these are two important points which I'd like to highlight again. And also the low vision alone, since the other eye has 6/6 and 6 vision, I think they may not accept low vision devices.
Yes,
So
you're correct, ma'am.
Case will be resolved in vision therapy other than giving low vision aids or surgical thing.
no, after surgery, we'll have to wait and see how the vision improves. And one important point they've highlighted is how the refractive error changes. That's an important point that you need to note down. Yeah. Very beautifully, you highlighted everything, Dave. So thank you so much for covering and giving us a comprehensive idea for all our students. Thank you so
Thank,
much.
thank you, ma'am.
Yes, over to Om Priya.
No doubts in the chat box, ma'am. So
Okay,
we'll wind up.
fine.
And thank you, students, for joining, and thank you, Dev sir, for joining and providing an extensive input, sir.
Thank
And
you, ma'am.
thank you all. Thank you, Jemima ma'am. And this will be posted in a live in YouTube link, so you can also see in later. You can watch it later.
Okay, then thank you so much. Good
Thank you,
evening,
ma'am.
all.
See you soon. Bye, ma'am.
Bye bye.